Krista Schulte. For those of you who don't know me, I'm a nurse practitioner. I work out at the Lakeland Center for Wound Care and Hyperbaric Medicine down in Niles. I'm certified as a wound ostomy and continence nurse, and I'm also certified in foot and nail care. So I've come tonight to talk to you guys about the diabetic foot. That's something we see a lot in the wound clinic. Ideally, we want to prevent you from getting to the point where you have to come there, but sometimes we have to step in and help for when a person gets a sore or cut on the foot that's not healing, and we need to step in and intervene. So hopefully I can teach you guys some things, whether you're diabetic or not, just some general things on what you can do to keep your foot healthy, appropriate foot care, and that sort of thing. So these are some of the things we're going to cover tonight. Diabetes is actually quite complex. That's a whole presentation in itself. So I'm going to focus specifically on how it affects our feet. We'll talk about some of the risk factors for developing a diabetic foot ulcer. Of course, preventative measures are always high up on my priority. And another thing is just knowing what your resources are. If you need help, it's important that you know who you can go to. So to summarize diabetes, your body uses food to make energy. In diabetes, the body doesn't do that very well. Normally, you eat food and your body turns that food into some glucose. You need insulin. Insulin is a hormone that comes from the pancreas. Insulin is what turns that sugar into energy by moving it into the cells. Well, in diabetes, your body isn't able to do that. You either don't have enough insulin or your body doesn't produce any insulin. So in that case, your blood sugar level rises, and that's when we have problems, when you check your finger and your blood sugar is elevated, or we do a urine sample and that shows an elevated glucose level. So in a nutshell, this is what diabetes does. So there's a lot of statistics on this page, but a very simple Google search will pull up all of this sorts of thing. In America, our diabetes rate has been increasing over the last several years. We're up to about 9.4% of our population has it. Regionally, these numbers can vary, and in our region, the last time we did a local incidence study, in Lakeland's region, we have about a 12% rate there. So in general, our community has a little bit higher rate of chronic diseases. So in our area, we may end up seeing more foot care problems because of this. Diabetes can be very costly to treat. They say it's actually up there more expensive than some cancers to treat. There's a high rate of developing foot ulcers. 10 to 15% of diabetics may develop foot ulcers. From that amount, 24% of those go on to require amputation. So at the end of all this, amputation is what we're trying to prevent. 67% of all limb amputations we do in the United States are because of diabetes. So those statistics are quite high and alarming, and we're really working as a community, especially and as a nation, to look at resources, what we can do to reduce this rate. So hyperglycemia does a lot of things to your body. Focusing especially on the skin, there's a lot of changes that occur. What type of changes occur depend on how long you've been diabetic and how high are those levels. Have you, gone several years with uncontrolled diabetes, or is this a new diagnosis where you are effectively going to get those numbers down? So depending on that, it depends on some of these other subsequent events here. But in general, your skin, its ability to produce collagen and tensile strength. When I have wound patients come and I'm teaching them about how the skin reforms over a sore, I talk about the collagen, and that's actually what the body uses to form new skin. In diabetes, you don't have the ability to produce that as well. Your skin strength, that tensile strength, is not as strong. It's also a little harder to fight off infection, and that really goes more because of the blood flow concerns behind it, and I'll get into that here a little bit more too. Slower rates of healing also is because of the effect on blood flow. The nerves, which is another big part of what I'm going to talk about in this presentation, is how the hyperglycemia can cause damage to the nerves, which may cause numbness and lack of sensation in your extremities. So what are the big risk factors? These are the same risk factors we have for a lot of chronic diseases, right? Smoking is a big one. Every time a person smokes, that immediately causes the arteries and vessels in our bodies to constrict. So smokers usually know that it's bad, it's not good for them. They generally know why, but sometimes they don't always think in relation to a wound. When a person comes into to the wound clinic where I'm at, they don't always understand how smoking affects that ability for any wound on their body to heal, because every time they're smoking that cigarette, those arteries constrict and it cuts the blood flow off from coming into that sore. So that's high on our list of things we're educating our people about to quit smoking. Overweight and obesity are problems because when you have overweight and obesity, there's changes in your body that happen. You tend to have a higher blood sugar rate, which contributes to these problems. Physical activity is another problem. Diabetics, when they exercise, they have the benefit of a lower blood sugar for 24 hours after that exercise session. So the general recommendation is to exercise 30 minutes a day, most days of the week. In diabetics, that's especially important. So that's high up on the priority list when we're teaching diabetics about diet, is also about exercise, because that is naturally low on our blood sugar levels. It's important that we get the high blood pressure under control and the high cholesterol, and that's because of the diabetes effect on the vessels, especially in your legs. Just like with heart disease, we can get blockages in the heart, the carotids, we can get blockages in the legs. When we get blockages in the legs, that cuts off the blood flow that's trying to get down to our feet. An elevated blood glucose level, a person that has an A1C level greater than 9 or has had a diabetes diagnosis for over 10 years have a higher a risk. And for those of you that may not know what an A1C, generally diabetics that are diagnosed know what it is, because that's the number you're always supposed to know. An A1C is a lab level that's drawn that looks at your average glucose level over the last 3 months. So it doesn't matter if you had a high sugary meal last night or this morning you had a Pop-Tart and chocolate milk. That number is going to tell you over the period of the last 3 months, when that blood sugar level goes up and down all day long, what is the average that's been. So they kind of turn that average into this number, and that's what we look at to know how well you're controlled. Generally, and I have this later in the presentation, but generally we want that number to be below 7. A number below 7 means we have good diabetic control. So all of those risk factors I just mentioned lead to these things. Peripheral artery disease, that's the change in the blood vessels of your legs and feet. We have a risk of causing these non-healing ulcers. Skin changes and calluses. Diabetics typically, because of some nerve changes in the feet, typically have much drier skin. They don't produce the moisture like non-diabetics. So we typically tend to see much drier skin. And you can see even in this picture here, we see some of these typical dry cracked heels. Nerve damage, I want to talk a little bit about neuropathy. This neuropathy is not specific to diabetes. We see people that have neuropathy that have never been diagnosed with diabetes. You can have it for other reasons, but this is probably one of the biggest reasons we see this. So neuropathy is a damage to the nerves. When we have a damage to the nerves in the lower legs and the feet, we kind of lose our ability to feel pain. This could be not feeling pain, not feeling cold or heat. It can also be a numbness or a tingling sensation. So sometimes people with neuropathy will say, I can't sleep at night. As soon as I lay in bed, I start having this tingling sensation that's uncomfortable. The other thing we see is, just like this little picture down here, not only does this mean sometimes those people with neuropathy feel like they have pins and needles on their feet, but they may actually step on that needle and not be able to feel it because of that change in sensation. 70% of diabetics will have some sort of nerve damage. We do typically see this in the feet, but you can also have it in the hands or the fingers, a numbness, tingling sensation, carpal tunnel, and even up into the elbow to have some of those nerve changes, and even nerve changes in the gut where our digestion is affected. So some of the signs that you may have a damage to your nerves is that loss of sensation. I'll show you here in a little bit by a picture of one way that we use to test that change in sensation, because oftentimes it's so subtle and so slow, people don't realize that I don't feel as I used to. Dry, flaky skin, as I mentioned, the pins and needles sensation, and I have up here bone deformity, because over time that change in nerve functioning of your lower legs and feet can slowly start to alter the bones and the muscles in your feet. So we get a little shifting of the bones, and you may have certain areas on the bottom of your feet that you're getting callus formation that maybe you didn't have before, because your foot structure is changing. That's why you don't just go see the foot doctor one time. You go back and you have follow-ups so you can watch for some of those changes. So I added this slide because a lot of people say, what can I do about neuropathy? And honestly, once you have neuropathy, it's not a cure. It's a matter of managing it, preventing it from getting worse. You know, sometimes it can be as simple as, you know, I have this tingling sensation, I'm uncomfortable, getting up and walking helps for some people. Other people may be getting up and elevating. When we have to go with something a little bit more because a person can't sleep at night, we can look at pain management, topical or oral, starting out with something mild if possible. This is more of a chronic issue, so sometimes looking at medications for nerve pain or anticonvulsants. Gabapentin or Neurontin is one of them, probably a lot of people have heard about, Lyrica. Some of these are the ones we hear most often that people take for this chronic nerve pain, and those dosages are adjusted according to the benefit they're getting. So these are things you would speak with your doctor about if you felt like you needed to try one of these therapies. So this is a general picture of some things you look at on your feet, because there's not a single spot that we're going to say this is where you're going to have problems. Up here, you know, this could have been somebody wearing flip-flops and getting a little abrasion here. Could have started out as a bug bite. It could be athlete's foot. Fungus loves a dark, moist environment, and they love sugar. So what better to find a place in between the toes on a diabetic where they have all of those things. So, you know, when I talk more about preventative things, these toe web spaces are very important to look at. We have a little spot here on the top of the toe, and I'll show you a picture of a hammer toe here in a minute, but this is a spot sometimes where we get some changes in the toes and you get some rubbing on your shoe. You can end up with a sore in that area. I think if you look over here, it looks like there's maybe a little ingrown nail here on the side. We have some redness and inflammation. This looks like probably a fissure on the heel, a little cracked, dry area. And then here we have problems with bunions, which is another thing some people have, and you end up with this little protuberance here that rubs on your shoes and creates a sore. So specifically a diabetic foot ulcer happens for a few different reasons. Generally, well, a diabetic foot ulcer is located on the foot, and we see oftentimes these start as a callus. A person says, I've had this callus, it just keeps getting thicker and thicker. What happens with that thickened callus is it's putting a lot of pressure on the skin, and it's actually causing injury underneath that callus. So we can get to the point where there's so much damage underneath there it starts to bleed and a wound forms. And it takes a little bit, but eventually we'll start to see the callus open up and it looks dark, almost bruised underneath there. We find out we have a diabetic foot ulcer now. So that's often how these start. But a diabetic foot ulcer could also be something like a scrape or a cut that just doesn't heal. You know, typically you get something like that, it heals within maybe a week or two, but if you have something that's persistent, you've had this for weeks, maybe even months now, it doesn't matter how it started. If it's on the foot of a diabetic, we're calling it a diabetic foot ulcer. These are two common areas. I mean, we see them on the tips of the toes, generally right here. These are the metatarsal heads. We'll often see them here because that's where we get calluses at. I kind of talked to you about some of the factors that lead to these sores. Here's that picture of the hammer toe I was telling you about. There's all sorts of, you know, go get a podiatry book, and there's all sorts of deformities on the foot and things that can cause problems. Hammer toes are quite common. Again, getting a shoe with a wide toe box is one thing that we can do to kind of help with this. We can get this, calluses, hammer toes, being on your feet and walking a lot can cause injury, cause something to start out as a blister. Scrapes and cuts, hot water, we see hot water. You know, I'd seen someone before that had been outside, got their feet wet in the snow, you know, probably borderline frostbite, couldn't feel it, but came in and then stuck them in front of a space heater and then ended up getting a burn from that area. So couldn't feel either one of those. So that's where with neuropathy, you may not have that sensation of heat or cold. So we have to, you know, take that into consideration. Trimming your toenails, we always say straight across because sometimes people want to cut kind of at the sides. We nick the skin or we leave a little sharp edge that grows into the skin and then we end up getting an ingrown toenail. Tight, uncomfortable shoes, those high heel shoes and those sorts of things can really scrunch the toes and cause those sores. So what do we do for treatments when we get any type of cut or sore or an ulcer? First thing we do if you were coming into the wound clinic or if you're going into your primary care doctor, let's get your blood sugar under control, because a high blood sugar rate, we know you're going to be at a slower risk for healing. So we work with your other providers. Let's get that number down, diet, exercise, medication adjustments if that's what we need. If there's infection, of course, we need to get that under control, oral antibiotics or antibiotic type dressings that we use frequently. I threw this out here about maintaining moisture and dressings because there's this theory out there. You know, a lot of people think we need to let air get to things, right? Let's let air get to it, let it dry up, get that nice little scab on there. And if any of you guys have seen me at the wound clinic, I've probably gone through this because that's usually one of the first things we get. You know, people get a little nervous because we want to keep it covered all the time. But keeping a cover on there creates a warm, moist environment that cells like to form new tissue. When we let things air out and get that dry crust on there, it acts like a brick wall. So now all of these little cells and growth factors, fibroblasts that sit around the edge of a wound, they can't move past that. So honestly, sometimes that antibiotic ointment that you may have in the cabinet at home, and a bandage is just creating that nice warm, moist environment that it needs to form new tissue. So no keeping things open to air, no using alcohol or betadine or peroxide. If you have a dirty wound, that's okay at the beginning, but when you use that routinely, it can actually damage those good cells trying to form in there. Removing pressure with offloading. When I say offloading, I mean we're taking pressure off of that sore. That can be in a lot of different ways. You know, if you're working with a foot doctor, he may make some modifications to your shoes, getting you some diabetic shoes, and I'll talk more about that. In the wound clinic, we oftentimes will use some sort of a shoe insert where we can kind of plug out the bottom of it to give you a little relief where that sore is. We also have these types of things. This is called a total contact cast. For a diabetic foot ulcer, this is sort of the gold standard in treatment of this. This is a type of cast that's put on weekly, so where we do the wound care dressing, put on a cast. It takes the pressure off of the bottom of the foot and distributes it up here into the shin. So this is one thing that we do commonly at a wound clinic where you might not get this other places. I put this picture up here. This is your Amazon shopping experience here. All of those things are some things that we could do to help things like hammer toes and, you know, if we have a sore at the end of the foot. You know, sometimes you can't truly fix a hammer toe unless you went in and you had surgery, which sometimes is something that podiatrists and foot surgeons need to do. You know, you can do some of these things. This is called a toe crest that sort of slips underneath the toes and temporarily straightens them as long as you have it on. So toe crest, like I said, there's two different versions here, are things that can straighten up a hammer toe a bit if you're having problems. I have also seen some of these. Some of these are made out of silicone or a soft cotton fabric that'll help if a person's having some sort of a rubbing at the end of their toe. So these things are available over the counter, Meijer, Walmart, all those places carry them. So we want to talk about prevention. That's a big thing to not get into these types of things. I talked about controlling your blood sugar. Checking your feet daily is one of the most important things we stress to people with diabetes. So every day before you go to bed, take a look at your foot. If you can't see your foot, get a mirror out and do it that way, or ask a family member or friend to look. I can't tell you how many times a person has stepped on a piece of glass or a needle, you name it. They don't feel it, and it sits in there for sometimes days before it becomes a big problem. The person couldn't feel it, and they didn't check their feet. So you may not have that sensation. It's really important to look every day. We say wash your feet with warm water, mild soap, but don't soak your feet. Now you're going to get some different thoughts out there. There's going to be some people that say soak it. There's going to be other people that say don't. If you have a wound, we never say to soak it, because having a wound and soaking it, you have risk for getting the bacteria in there and getting infection. But in general, the reason we generally say don't soak your foot when you're diabetic is, number one, remember you don't have that heat sensation. So people have gotten burned before by getting that water too warm. Number two, when your skin soaks up all that moisture because you've been soaking it, you know how your skin turns white? it's waterlogged, that wet skin is more prone to injury. So we don't want to put all of that extra moisture in there and then have risk of it breaking down because of that. I said lotion's important, but not between the toes. And again, we don't want to add extra moisture to an area that's already moist. So put it everywhere else between your toes, and you may ask what type of lotion. I generally say not the bath and body type lotion, right? Get a lotion that's non-lanolin is preferable. Something that doesn't have all of the scents and irritating things like that. Gold Bond lotion, there's one for diabetics that's common. Eucerin, Lubriderm, Aquaphor, CeraVe. There's several out there on the market, and you can find those at just about any drugstore. Corns and callus removers are also no-nos, as is cutting them off yourself. But the corns and callus removers, you're putting acid on that area of skin with a corn, and then usually it comes with a little bandage. And I've seen pictures where people have done that acid with a dressing on it, and it actually erodes through the skin by the time they come through to much deeper than what they wanted. So again, seeing a professional for that, you can help get those removed. I talked about cutting the toenails straight across. Wearing socks. Socks help absorb moisture, plus they also give you some cushioning to your feet. Footwear at all times is probably the #2 thing I talk about besides just looking at your feet every day. So footwear at all times is kind of a given when you leave the house, but generally people come home and they like to take their shoes off. Well, honestly, at home is most of the time where I see that people have stepped on something and caused an injury and didn't realize it. So having a separate pair of indoor shoes is an idea, but you need that support and protection on your feet at all times. Podiatrist visits should be regular. Depends on your insurance. Some people have insurance that cover podiatry, other ones don't. Medicare is kind of has more set guidelines. Generally, they can get routine foot care approximately every 60 days. So that's something that we recommend. We know diabetes affects the eyes also, so generally we're telling people get your eye exam every year to keep up on that. You should see your primary care provider. We're supposed to get that yearly physical. So part of that yearly physical should be having your feet checked. So if you're seeing your provider, if they put you in the room, go ahead and take your shoes and socks off because you want to make sure that they're giving you a good close look over. When you see your primary care provider, these are some of the things they may do. If you go to a podiatrist, you may see that. When you come to the wound clinic, we often do some of these. The main thing we do, honestly, is called a monofilament test. And this is it's a filament. It's a filament fiber that we tap on several areas. There's about 10 places on your feet where we go through and touch your foot just enough to bend that. So it's honestly quite a light sensation. Normally you would feel it with no problem, but if you start to lose a little sensation, we may notice you have a few areas not the greatest sensation, and you may develop to the point you don't have any. But it just gives us a baseline. We do this every year so we can see where we're at. It kind of gives you an idea. Okay, last year I could feel all those areas. This year I only felt, maybe half of them. Well, it gives you reinforcement. I really need to make sure I'm checking my feet and keeping an eye on these things. But these are all the areas we would normally check with that. Vibration sense is another thing. Honestly, it's not done a lot in general practice, but we use something like a tuning fork and cause it to vibrate, and we hold it up a few places on your foot. The vibration sense is one thing we do. The other thing is position sense. All of these we actually have the person look away because we're either touching them on the feet and we're saying, where do you feel it, which foot? We're doing the vibration. We cause the vibration, stick it on there, and then we actually cause the vibration to stop, and we say, tell me when you don't feel this anymore. The position sense, we're actually moving your toe. We're taking it, we're moving it up or down and seeing if you can feel that change in position. Temperature testing is another thing. Honestly, it's not generally done in practice all that much, but that's testing your ability to feel cold or warmth on your feet too. These are some other things that are really done more by your primary care provider or maybe an endocrinologist. An endocrinologist, I haven't mentioned that yet, is a physician that specializes in endocrinology, and diabetes falls underneath that. So sometimes when a primary care provider will generally work with you, but if they're having a hard time getting it under control, that's generally where they refer you on to a specialist to manage that a little better. Diabetes, we know that some of the organs it really affects, I would say the three things we really watch for is the eyes, the kidneys, and the feet. So looking at the kidney function, retinopathy is the eyes, and that's why we say do your eye exam. But we're also looking at your lower legs in general, checking the circulation. Heart disease is always something that we check as part of your physical, and with diabetes. Looking at your skin and nails. I didn't mention with diabetes you often get thickened nails, and that bothers a lot of people. Why are my toenails so thick? A fungal infection in the nail typically only affects one nail or part of a nail. If every single one of your nails are thick, it's probably more related to diabetes and blood flow changes in your feet. We always ask smoking. People kind of get tired of being asked all the time, do you smoke? Have you quit smoking? But it's our way of just kind of positive reinforcement. How can we help you? Because that is so important with diabetes. And then checking your A1C level. It depends. Some people get it done once a year, every 6 months, every 3 months. Generally, we never check it sooner than 3 months because, as I told you, the A1C is it's a 3-month average. So if your number is elevated, we're going to say we'll make some changes. Let's recheck you in 3 months. So these are the things you can modify. You can't always take away, things like genetic risk factors, but these are things you can. You can stop smoking. We can work several different things, work with other providers, try to get that A1C below 7. If it applies to you, losing weight, sometimes just even a 10-pound weight change can make a difference in those blood sugar levels. And I talked about exercising. General recommendation is at least 30 minutes. Most days of the week. They kind of change that sometimes and throw out numbers, but now they say most days is what's recommended. So I'm not a footwear expert, but I did want to talk about, in general, some shoe practices. I mentioned the high-heeled shoes, sandals, open-toed shoes. Really, diabetics, these are a no-no because it's all about protecting your feet and keeping you from having injury. Socks and without seams, sometimes those seams at the end of socks can cause problem and pressure. So ideally a cotton sock that doesn't have that on there is the best thing to use. Before applying shoes, stick your hand in there. Make sure there's not a little pebble in there or anything that might be stuck in there that you wouldn't feel once you get your shoe on. But generally a good shoe should do all of these things. It should take off extra pressure, reduce the shock. There should be a nice cushion in there, and it should be able to stabilize and support your foot. So diabetic shoes are a wonderful thing. You can get diabetic shoes through a foot doctor who often will do those there. Diabetic shoes are molded. They actually take a mold of your foot. You actually stand barefoot on this little mold, and then they custom make inserts for you. So they are made specifically to fit your foot to give you pressure relief where you need it. Podiatrists will often do this also, and they use their own company to order the shoes. Your primary care provider can write a script for you and go to a DME company, Vans Medical, for example. I know the brand they use is Dr. Comfort. So they do these inserts, and diabetic shoes have come a long way because they used to look like diabetic shoes. Now a lot of them look like any other shoe. You can get a shoe that you would wear to church. You can get a house slipper. You can get a tennis shoe. They make something for everyone basically. But they provide a lot of support. If you're diabetic, the shoes are a little easier to get. Certain insurances are easier to get. I'm probably jumping ahead of myself on the slides, but generally diabetic shoes with those who have Medicare, certain Medicare plans, can get a new pair of diabetic shoes and inserts every year. Other insurances, I'm not going to have those answers specifically. That's something that sometimes we just have to run it through insurance and see. But those that maybe don't qualify for diabetic shoes, but they still want to make sure they're getting a good, well-supported shoe. This is not all-inclusive, but Power Step is one brand of podiatrists tend to like this brand of an insert. You can get these off Amazon too, by the way. It's just a good supportive insert. They make them for high heel shoes, even regular shoes. Bionic is just another brand of shoe, and there's plenty of other ones, but this is one I know I've seen at Vans Medical, for example. And they make everything from little boots to sandals, which diabetics aren't supposed to wear. But they make all sorts of these different shoes that, although they're not diabetic, they are much more supportive and comfortable than your typical shoe, typically lightweight too. So I mentioned this, seeing your podiatrist or a primary care provider. But generally, any diabetic I say you really need to get established with a foot doctor, because they're really going to look at those calluses, keep those trimmed down, taking care of your nails, and you may not think you need them so much now, but you may get to that point. It's just good to have that relationship established so you have someone to go to. So it's always important to know your local resources. There's a lot of things we have out here in our community to help the different avenues. We have a community support group known as AIMS, and some of you may have been involved in that. But that's actually through Lakeland. There's more information on the website you can get about that. Sometimes just having a group of people is helpful to ask questions and just to have the education, because they often have presentations and things like that for you to learn. I mentioned Vans Medical Equipment because they have the shoes. There's 2 different locations there. We've used American Limb and Orthopedics for certain custom inserts we need. Sometimes a person maybe has already had a partial amputation or something with the toes, and we need some adjustments of the shoes so they're not rubbing in that area. So American Limb and Orthopedic. Another local one is down in South Bend, Midwest Orthotic. And again, these aren't all inclusive. I'm sure I've missed some things, but I just wanted to throw a few up there for you. I also have created, I have this handout up here if anyone's interested, but we have a handout here of local podiatrists. I tried to get everyone on here, but there may be some, if anybody sees anything I'm missing, let me know, but this is just more of the local area here in Michigan. So we've kind of covered St. Joseph, Niles, South Haven, Dowagiac. And most of these will do preventative. There is an exception, I believe. I have Dr. Maskell up here, and I don't think he really does preventative stuff, but he does do surgeries and that sort of thing. So I wanted to bring that resource if anybody would like to be able to get that information. So that's my information. If anybody has questions.
Do you have any tips on improving blood circulation in your foot?
Well, yes, there are some things. A lot of these things are chronic. They may not necessarily be reversible, but generally if someone has a problem with the blood vessels, we do those things I mentioned before about stop smoking, regular exercise. If we have a diabetic come in to our clinic and we're doing an assessment, another thing I didn't mention up here, but we're checking the pulses on their legs or on their feet. And sometimes we get out a Doppler machine and we listen. There's not a set guideline that says if you're diabetic and you're over the age of, say, 65, that you should go have a test done of the arterial circulation of your legs. But if we have concern on your lower legs, then we may send you to have that test. So we're looking, do you have hair growth on your legs? I know that sounds like a funny thing, but are we seeing hair on your toes? If we have someone that doesn't, maybe they used to have hair and they don't have it now, that's a sign that maybe you have a change in your artery circulation in your legs. We also look at things like, if you were going to get up and leave this room right now and walk to your car, you get halfway there and your legs kind of get achy and painful and you feel like you have to stop, rest for a minute, then you're okay, you get going again. That's called claudication. Some of you have probably heard that word. That's another sign that you may have an artery problem. If you hang your feet down and they look like they turn almost like a purple, ruddy red color, that's another sign. So a lot of times I'm asking people these questions when I have a diabetic, and if I'm seeing some of those warning signs, and I say, okay, we probably need to go get a test done of your legs. If you're a wound clinic patient, I would just send you there to have that done. If I'm saying some of these things and you're saying, yeah, I kind of have that, no one's really looked into it, you probably need to go back to your primary care provider and say, hey, can I have my arteries checked? Specifically, well, there's a big word for the test, but it's a type of ultrasound procedure where you go to radiology, you have blood pressure cuffs put on your legs, and you have an ultrasound done. And they can go do that to find out what areas maybe show a little occlusion and how severe that is. Based on that information, we decide, okay, do we need to send you on to a specialist that specializes in the vascular part of the legs? Because sometimes those go on to need to have stent or angioplasty or something like that to open up that blood flow. You're welcome.
Any other questions? Here you go. Here's the microphone.
Hi.
watched the Channel 16 on the news, and they was talking about mouthwash slows down insulin production. Have you heard that before?
I have not heard that one. Mouthwash slows down insulin production. Well, is that if you swallow it or spit it back out?
That's all they said. So I've been asking around.
No, I've not heard any medical backing of that unless that's some new thing. I don't know. Sorry, I don't have an answer on that one.
Okay.
Yes, ma'am.
What about cramping or shooting pains in the toes?
That could be a few different things. Neuropathy, a lot of times people will say they just sit there and all of a sudden it just feels like something sharp, almost like a lightning type pain. And sometimes it'll come and go quite quickly. Generally, that's a neuropathy pain. I wouldn't say I could diagnose someone specifically off that, but that's oftentimes what we'll see. Neuropathy can present differently with some people. Like I said, some people it's just, I just don't feel anything. Other people, it can be quite painful, that pins and needles type sensation and a shocking feeling.
Do you have to have a referral to a foot doctor?
Well, it depends both on the foot doctor and it depends on your insurance. A lot of times specialty clinics, it's based on your insurance. Some insurances require you to have a referral from your primary care provider for them to pay for it. So, when in question, you can always call your insurance company. The other thing is just calling your foot doctor. I think most of them you can just call and they'll get you in, but I think it's always good, either you're checking with your insurance or oftentimes the podiatry office will do kind of like a prior auth and call your insurance company before you get there. Yes, sir?
I am diabetic and I have the numbness in my right foot and no sensation for heat or whatnot, cold. But the last few months I've been taking turmeric capsules and it's reduced the numbness quite a bit. And I've heard, I just recently read where turmeric with black pepper will even help it better. So the next time I run out of pills, I'm going to try that.
I've not heard with the black pepper. I have heard that, and I think cinnamon is actually another one that they say. I mean, there's a lot of herbal supplements and vitamin supplements out there in the market. They don't always have, they generally don't have that FDA approval that says they are approved for this. But there's a lot of homeopathic therapies that work very well for some people too.
Well, I've got a really weird thing my doctor's never heard before. My left foot can be really cold, and at night I need a sock on it, even in bed. But my right foot was extremely warm. I'd have to put it out from under the covers. I still don't feel cool. But at least with the turmeric, now I'm getting a better sleep.
That's interesting. Very good.
It's crazy cold or whatnot.
Well, glad you're finding relief.
Is there any kind of lotion, creamer you can put on the bottom of your foot?
Yeah, and I mentioned a few. I have a few of my personal favorites, but yeah, and you know what? I should have made a list for that because we get a lot of people actually say, "What's the best lotion to get?"
For the hypersensitivity,
Specifically for the nerves, like a type of lotion, not over the counter. I mean, there's some topical pain medications that would be similar to what you would use for arthritis, but as far as a type of lotion that helps with that in general, not really. Now, there are some lotions over the counter. Sarna lotion is one. That's a type of lotion that has Benadryl mixed in with it. So people, sometimes with diabetes, people have that dry, almost itchy skin. So sometimes I've sent people to get that type of lotion over the counter to help with the itching.
Thank you.
Is it all right to scrape your feet
No, you really shouldn't.
if you have a lot of dry skin on your foot?
Yeah, you know what, I'll be the first one to admit, I'm kind of, I got my little foot file and that sort of thing. But when you're diabetic, if you have good sensation and you're very superficial, sometimes I'll say, okay, I kind of cringe a little bit. Someone asks me, I'll say, okay, yeah, maybe. But general practice, they say not to, because again, because of your inability to possibly feel pain, in the process of doing that, you can get too deep, you can cause a cut or crack in your skin, you end up with an infection. And again, that's where if that's a repeated problem, then a foot doctor is helpful. Oftentimes they have sanders they can use to actually sand that down better to do it for you. You know, if you can get some of that skin thin, there are some good lotions, and there are even some prescription lotions that help that skin from overproducing that thickened tissue. So generally something over the counter like that to help soften the skin is better than trying to scrape it yourself.
Okay.
When you have a callus and you go to a podiatrist, you come to the wound clinic, we'll typically use a sharp instrument and we'll do a very measured type shaving down of that callus. But that's really something you should let someone else do. Yes?
Just for the video record.
Is cramping a symptom of diabetes? I noticed in the last few years I can wake up with a cramp in my right foot when I'm getting that one out. I get one in the left foot. And I seem to have a lot more of those than I used to.
Yeah. You can get cramping in your legs for a lot of different reasons, and you know, that's maybe a better question for your primary care provider. Certain medications can cause that. Electrolyte changes can cause it. Yes, diabetes and a change in your circulation can certainly contribute to that too, but there's a lot of things that may cause that. Your diet, nutrition in general, things like that too.
And the
The use of the hyperbaric chamber decrease the amputation rates around here?
Oh yeah, I mean, hyperbaric oxygen is another one of those things that could be a whole nother presentation. Most wound clinics do have what we call hyperbaric oxygen chambers, and it's a type of treatment that we do that you get into a chamber, it lowers the atmospheric pressure in combination with 100% oxygen. So we really force oxygen into the cells and tissue of our body. That actually works great for diabetics because generally a diabetic foot ulcer, we have a lack of oxygen and blood flow in that area. So it's a great therapy. However, it's actually very, very expensive. Insurances don't like to just pay for it for anything. So there's very strict qualifications. A diabetic foot ulcer generally has to be quite deep and quite severe for them to cover it. But we do hyperbaric oxygen treatments for other things too. And we have saved a lot of limbs from amputation, you know, on an emergency basis that we've had to get into the chambers. So it's definitely something that's been very beneficial to our community and every, you know, wound clinics in general that we have this, as long as we can get insurances approved and safely get the person into the chamber as well. There's, you know, certain physical things that person has to be qualified for the most safety to go into one of those chambers. Thank you. Mm-hmm. Yes, sir.
I've just been diagnosed with diabetes, but my AC is like a 4, so I'm on metformin.
Okay.
Is there a painless way to test for sugar, or do I need to?
Is there a painless way?
Yeah.
Other than sticking yourself.
No. If we can invent something, I mean, it shouldn't be painful. I mean, there are, I guess, I don't know what your little lancets look like. There are.
I haven't done it.
Oh, you haven't done it?
No, I don't know anything about it.
Generally, okay. Well, generally, it's not painful. I don't know. I don't know if anyone in this room would like to speak up to that, but yes.
When you do the testing, everybody shows the picture showing right on the pads of the fingers. Do it on the edge. That helps a lot. Yeah, do it on the edge, on the bottom.
Don't be scared.
Plus, after you do it a couple times, yeah.
Yeah. Yeah, it's scarier, it sounds scarier than what it is. Same thing when, you know, people get nervous about having to start taking insulin for the first time, but honestly, the needle is very small and thin, and you don't really feel it so much.
Have you ever had a flu shot? It's less painful than flu shot. And you can.
I screamed at that, okay?
Much, much less. But if you do it on the side of your finger, like he said, you can also get more blood. So you don't have to have the depth. What do you call call that where you've got the 1, 2, 3, 4, 5. For the depth of how far that needle goes in. Just
Yeah.
your depth, I guess. So if it's, you know, you can have it at a 1 or a 2 on the side of your finger, and you can get more blood.
Depends on what type of lancet device you have.
Yeah.
Some of them have the ability to adjust that, other ones don't. And, you know, again, I recommend especially, you know, if you have friends or family in, when you can ask questions, that's helpful. The community support group's another way, that, you know, usually it's a very small group, and, you know, if you have questions, that's sometimes the greatest place to go and talk to other people that have gone through that too, so.
Krista, will you stick around in case people want to ask you some
I sure will.
questions? Okay, well, a round of applause. Thank you so much.